really the basic concept here is that this is really one population. And let me back up a little bit. What I mean by one population, some program statistics give you monthly slices. 406,000 in January, the IHSS population. I hope I got that number right. 37,000 for ADHC. But another way of thinking about this is actually also, for example, March 2011 data shows there's roughly 68,000 Medicaid people in nursing homes in the state of California. But there's also an annual unduplicated count that's different than just the monthly snapshot of a particular month. So in in the adult day health care program, the yearly turnover through the program could be 55,000 people. Roughly 115 or 120,000 people potentially use nursing homes. I'm sure there's a substantial turnover through the IHSS program as well, plus other waiver programs have that kind of turnover. And one of the things that we didn't do in the report, in this 300 pages with its acronyms and glossaries and bibliographies, we didn't actually make an estimate of the long-term care population. But my bet, when you start adding up the unduplicated yearly count of everyone who goes through it, you could be hitting 800,000 or 900,000 people. Wouldn't surprise me to get a number that high. And what isn't being done is to think of that as one population that happens to go through particular programs at any given time, but over the course of their trajectory in the state's programs will go through multiple programs or back to programs they went through before. And there are at least, and that gets to the question of a database that keeps track of people in the program. And that gets into the concept of a single assessment that collects the same kind of assessment information on each of the people in the program. And how you go about building that kind of database. Now, there's several there are conceptual tools that people in California simply lack. I mean, the state hires these really bright, smart, hardworking people and then doesn't give them good management tools and tells them to go run their programs. And so, for example, I passed out this sheet here. Now, the printing is so small as to make it unintelligible. But what it is, it's a document from North Carolina on case management services. And what it shows are the same programs are in the rows and the same programs are in the columns, and each cell of the table shows a person who is getting case management in each of those two programs where the programs intersect. And when you go through here, you could see that in a given program, people in that program may be getting case management in 3 or 4 or 5 other programs. And you can only produce a document like this if you're keeping track of the population as a whole on an individual basis and where they're getting services, what programs they're in. And so this then helps to get at questions like fraud and abuse, or at least ask the question of whether or not the case management services that they receive are similar or different, if they're actually duplicative. Another kind of example of data is one that, as a manager in the Oregon Long-Term Care Services Program, I spent 6 years as a senior budget analyst there, and I worked as a manager in seniors and persons with disabilities. But every month, as part of just the routine MMIS flood of paper and tables that we got, we had a table that showed in the rows showed what program persons were in at the beginning of the month. The columns showed what programs they were in at the end of the month. So you could tell how many people went from one program to another each month. And you could just track the flow of people back and forth across the programs. So for example, if you had one for California, you would know how many folks started in IHSS at the beginning of the month and where they were at the end of the month, what the flow was, how many went to nursing facilities. See? How many who were started in ADHC ended up in nursing facilities. We had that kind of routine report that we got every month that answered these kinds of policy questions.
Well, and it would seem that if we had the data collection structure, infrastructure in place, that with all the technology that's available to us now, it should not be that difficult.
I don't think it's that difficult. I mean, this is a...
Have we made it harder than it really needs to be?
Well, we have a, yes, I think so. We have a geographical location in California whose name is synonymous with computer excellence. You know, I mean, we have great computer companies that were built in garages in this state. Every day we're surrounded by these phenomenal systems that we take for granted. When I go to Walmart to buy my toothpaste, the Walmart point-of-sale machine knows I was sold a tube of toothpaste, sends it to the inventory factories, which keep track of exactly how many tubes are in that store. And then so when enough are sold, it ships them a box automatically. And if Walmart can keep track of toothpaste, why can't we keep track of people in long-term care programs? Now, a third concept, and one that's used in Oregon, and this is this document called Seniors and Persons with Disabilities. It was also passed out outside in the hallway on page 9. I'd like you to turn to that table on page 9, as this is actually a pretty significant kind of table. And what...
In here, okay. I have lots of documents here.
I understand.
Okay.
But in this one table, you sort of capture the difference between having an organized system of long-term care and a system that's not that well organized. And it's on page 9, and what it shows in the columns are the names of programs, and in the rows it shows what are called SPL. These are actually survival priority levels, and there used to be 17 of them. There's only 13 now, but what they are is their assessment information that has bucketed people into levels of impairment, such that the people in level 1 are the most severely impaired, and the people in level 13 are the least severely impaired. There used to be 17 levels, because what happens in Oregon is when you have to cut the budget, you take the least impaired people out of service and you move up the priority level. Now, that's a really significant concept, because what it's saying is that if you don't have the money, you reserve the money for the people who are most impaired. That's where you put your scarce resources. And you'll notice then that there are people, in every level there are people spread across all programs. So in California, what we do is we go down a column and bleep a whole program. You know, MSSP, a little line item. You know, ADHD, well, there are a lot of troublemakers anyway. Click, you know. And what you do when you do that, you take out people who are heavily impaired and people who are lightly impaired. And what you do then is you leave behind other programs which, because for whatever reason, are relatively less touched, where there are people who are less impaired, and you're taking out people who are more heavily impaired in these programs to get totally line-itemed.
Well, that's because the approach is generally a one-size-fits-all in the deliberations here, and I think sometimes, because of the size and complexity of California, just population-wise, as well as all the budgeting and all the fiscal emergencies that the state has sustained year after year after year. But we have to get away from the one-size-fits-all because it's not working.
Having better data and understanding the characteristics of the people in the program and basing your data system on individuals enables you to at least inform your policy making better by being able to have a more grounded philosophy of trying to take out people who are the least impaired regardless of what program they're in. Because as you look at Oregon, really at the highest level of priority, number 1, you'll see that in that there's roughly 1,940 individuals in that level currently as of June 2010, and only 895 are in nursing facilities. I mean, half the people who are the most seriously and heavily impaired are not in nursing facilities in Oregon. And I dare say you'll find a similar kind of situation. I don't know if the percentages are the same also here in California as well. The programs outside nursing facilities are also serving people who are very badly impaired. And so that's at least 3 examples then of the uses to which an assessment instrument and a database that covers that collects information on the costs and the acuities of people and enable you to manage the program as really one whole group of people rather than having each department try to manage a separate program. These are examples of what other states do along this line. And
why do you think this, the holy grail of the, uniform assessment tool has been such a problem? Because I recall still being at the Yolo County Board level, a time when we just internally at the county level tried to achieve a uniform assessment and uniform, data reporting across adult protective services and other agencies that would touch upon adults, mental health, criminal justice, you name it. But we found even within Yolo County, and I know our assistant deputy is listening there from Jim Provenza's office, Sheila Allen, that there were all of these legal issues of confidentiality and we can't share data and HIPAA and so on and so forth. And yet we're able to do that on the children's side, but not on the adult side. Did you find any of that?
I haven't studied the assessment efforts that have been made in California. We came across vignettes like San Mateo's attempted work. My general impression is that if you're talking about people who are entirely Medicaid eligible, there should be no HIPAA problems, regardless of what department or program they're in. And the lawyers tend to exaggerate the HIPAA problems, because theoretically it's all Medicaid eligibility issues. They're all Medicaid eligible people here. One issue is folks say, well, this assessment instrument won't work on my population, so you can't use it. It doesn't have enough cognition in it, doesn't measure dementia properly, doesn't cover developmental disabilities. It can't be used for reimbursement purposes. So the effort, I think, is to I don't see any reason why you couldn't start with the IHSS database on ADLs and then pull out data from the MDS data for nursing homes and kind of get at least a kernel of assessment information. I also, and I'm now sort of leaping into later comments, but I don't see any reason why the state couldn't issue an RFP to have a contractor develop one. Just put it out for bid and see what happens. And get some estimates back on what those costs are. The state of Colorado, it's costing them $3.5 million to develop a statewide data analytics coordinator to handle 500,000 people in their managed care and in their new health care expansion programs. It's doable. Folks just have to, someone just has to decide to do it. Instead of not doing it. A unified long-term care budget is it's really, when your programs are all organized in one house, you can put them all in a single budget, and the puts and takes from one can balance each other off. Now, I know that a lot of the discussion in long-term care is gets cast as a form of bad institution, good home and community-based care, but when you're actually working a long-term care budget, there's really a multiplicity of programs. And I'd like you to turn, just to get a sense of some of Oregon's programs, page 4, down at the bottom of this document called SPD Overview, on page 4 shows that Oregon has a broad range of programs. It has 1,700 foster homes with 7,200 beds in them, of which 37% are Medicaid, 209 assisted living with 14,000 beds, of which 29% are Medicaid occupied. 236 residential care facilities of 8,900 beds, of which 26% were Medicaid. 140 nursing facilities with 12,000 beds, of which 38% were filled by Medicaid residents, and 1,800 foster homes, relative foster homes with 1,500 Medicaid residents in them. And
they're for adults, not children. Is that correct? Some are maybe
yes, usually adults. Usually adults. That's right. So what you see is if you have what's called a balanced program, it's a program with a lot of long-term care living varieties and settings for people that attempts to provide them for the entire population, not just a Medicaid group. Okay, that's one of the noticeable things here is the minority presence of Medicaid in every Medicaid paid program that is here. Okay, plus, so when you're a manager in the program and you have this variety of programs and you have a good case management structure, which Oregon did, what those case managers are doing is saying, well, assisted living is more expensive than adult foster homes. Now, is it possible that this person could use an adult foster home rather than assisted living? And so it's a trade-off of a higher cost option versus a lower cost option, not just a trade-off of nursing facilities versus something else. It's really 5 or 6 or 7 trade-offs that you're working to make a cost-effective program. And when you have a unified budget, you can then decrease expenditures in a higher cost program and increase expenditures in a lower cost program, coming out with a better net bottom line. Now, what happens in a place like California is when your nursing facility budget goes down, those savings are taken to pay something else, a deficit, bonds, roads, parks, schools. And when a home and community-based care option goes up, then folks cut the budget because it's obviously out of control. So it's like a reverse engine. So in a more unified budget, you have a possibility of exercising effective cost control, taking those savings that you're getting out of that cost control, and then putting them into lower cost alternatives and expanding them so you can further cycle savings and pay for those additional programs, those additional slots in home and community-based care, for example, and still keep your bottom line what the legislature wanted it to be. So,
did you find during your studies that you examined anything related to the explosion of the autistic population in our country?
We didn't study that. Clearly, in California, there are definitely problems with autism.
Well, because that is the diagnosis is so high now, at least that is the latest published information. 1 in 110 births, or children are being diagnosed, and thankfully people don't pass away of autism, they become adults with autism. And the long-term care needs especially post-education, and we just saw what happened with some of the transitioning in the May Revise of various support programs, mental health, as well as other shifts to the school program until someone reaches 18, but once they reach 18, they're no longer served by school systems. So that was not part of the purview.
No, well, our report didn't touch on autism. In the summer of 2009, I did work on a study of the Texas Early Intervention Program, so probably the largest in the country, and we studied some 10 other early intervention programs in the country, and it is clear that autism and how to pay for it and a differential rate for it are a troublesome problem in early intervention programs. States are just dealing with them in different ways, and they're in just really the initial 3 or 4 years of sort of scratching their heads trying to figure out how to cope with it. In terms of a unified long-term care budget, some 14 states either have such a budget or are talking about such a budget. A Department of Long-Term Care Services and Supports or Adult and Aging Services. Vermont, Washington, Wisconsin, Pennsylvania, Texas, they've all had some consolidation of services. I think that Pennsylvania is really an excellent model for California to look at. It's I say that in part because of its size. You know, I think it's the fourth largest state in the union. Maybe the fifth, and it, there's California, New York, Texas, Florida, Pennsylvania. They're the top five. But Pennsylvania, it had its long-term care programs scattered in two major departments, aging and welfare. And what they did was they appointed a deputy secretary in both departments, same person. They made him report to both departments, consolidated the programs in the Office of Long-Term Living, so they were able to get a consolidation, a de facto consolidation. And in the same way that it's not, and I probably, if I knew more about the agency, I would realize it was a total fiasco of a suggestion, but the secretary of the agency might consider such a de facto consolidation. I think one of the great contributions of the Little Hoover Commission's recent report is the emphasis on leadership. That theme comes through repeatedly, and I don't see why you couldn't have a de facto consolidation within the agency. That's where the programs are, and finding a good leader and then figuring out a way to do that. You could still house some of those units in other departments and let their public relations and their human relations and their budget units feed them, and house them, but still nonetheless have them report to some consolidated structure.
I like to think the fact that Jerry Brown, our wonderful governor, is himself 73, I believe now, and was both the youngest and now the oldest governor of our state, that, he might have that perspective. So, we hope to enjoin him and his Health and Human Services Secretary, Diana Dooley, and others, in that discussion. But we've had a few other major issues to deal with before that, so we certainly wish him well in that endeavor as well. But some of the reason that we're having this hearing today is the fact that, as we heard, the budget situation has really shredded a lot of our existing systems for the adult population. And in the direction that we're going, it's really, it's really a collision course with disaster. People are going to die sooner, in my opinion, and they're barely hanging on. And so I'm hoping that, as we continue with this series of hearings following along with the series that we did last year, I'm actually somewhat weary of talking as well. We've been talking about this a very long time. But anyway, please continue. I know we have a few more minutes, and then we'd certainly want to.
I do want to mention about the cost effectiveness of nursing home transition work, and I want to come back to it later in my comments too. But that was one of the recommendations in our report. We talked about it at length. It's a recommendation 11, and what I did was I looked at the Medicaid occupancy of states that have effective nursing home transition programs, in my opinion. For what it's worth, I'm on the CMS Technical Assistance Panel for Money Follows the Person, so I get a good bird's eye view of what goes on in other states. I've done some studies in these other states like Pennsylvania, and I just want to read, there's at least maybe 8 states that I think, just off the top of my head, I think have very effective nursing home transition programs. And I want to read the percent of Medicaid occupancy in their nursing homes compared to a California percent of 66.6%, okay? Okay, so Michigan, 62.7, New Jersey, 62.8, Nevada, 57.6, Oregon, 61%, Pennsylvania 62.2, Texas 63.1, Washington 59.9, Wisconsin 59.8. And the average of these states is roughly 61.13%, okay? About 5.5% lower than California, right?
And that's adjusted for population. It's all adjusted, right?
No, it's just Medicaid occupancy.
Just Medicaid
It's just Medicaid occupancy, the percent of occupancy.
Okay.
The total occupancy is quite variable in these homes. I mean, from a low of 66% in Oregon, where you just have what must be homes that are just almost empty at 66%, Texas at 71%. Almost everyone else is up in the 80s% on terms of total occupancy. And also, just for comparison, I picked 3 states where, in my opinion, don't have really a great reputation for nursing home transition work, just so you can look at their percentages. Alabama, 68% is their Medicaid occupancy. Mississippi, 74.5%. West Virginia, 72.2%. Substantially higher than California and these other states, which are at 61%. Okay, now, if you look at page 115 of our report, it shows there were roughly, in calendar year 2008, there were $3.8 billion in expenditures for nursing homes. I assume that's a total and a general fund amount. It's a total, it's a combination of federal and state funds, $3.8 billion. Well, just roughly, okay? 10% of $3.8 billion is $380 million, and 5% is around $190 million. And now you figure that 5%. So earlier I said there was a 5.5% difference in Medicaid occupancy. So what if you could reduce your Medicaid budget by 5%, okay, you could save them $95 or $100 million a year. I mean, I think a nursing home transition program can be cost effective. I mean, okay, so
sounds like a good round number.
It's a I did this off the top of my head. It's not in the report, but I think you can look at statistics like this, get more up-to-date data than 2008, and actually, quantify some expected savings that you could get out of an effective nursing home transition program. And I don't want to try to say that it's actually going to be for sure 95 or 100 million a year, but I think if you do, if California had an effective nursing home transition program, I don't see any reason why it can't bring that nursing home occupancy down another 5% of folks, and down to like 61% Medicaid occupancy. That's kind of a reasonable goal, given what other states with good programs are doing. I'd like to, there are a series of recommendations that we had that tended to deal with payment reform. And so I just want to mention some of these, and not try to go through them quickly because of the time of the afternoon, but about 30 states use a case, this is recommendation 6, about 30 states use a case mix reimbursement for nursing facilities, and by that I mean they base the staffing part of their payment on the acuities of the individuals who get the services. This is the way Medicare does it. Medicare is 20% of the nation's health budget. It's probably the largest, most sophisticated health insurance program in the world, probably. It's for 10 years now. It's just rigorously adopted payment systems that pay for impairments of individuals at a level. The DRG system in hospitals and intensive rehabilitation facilities have such a bucketing of folks, and so providers get paid more for taking care of heavily impaired people and less for taking care of lighter impaired people, and that's really probably the best way of reimbursing programs. You had tying it to the acuity of the individual you're paying for in some way, and I think California would be well advised to adopt such a system. When we recommended it, everybody groaned because of the long struggles over AB 1629. And said, "Oh no, we're not going to go there again." But nonetheless, it makes good sense to have such a program. We also recommended trying to develop an acuity-based system for home and community-based care. So you reward providers for taking care of heavily impaired people and pay them less for taking care of lightly impaired people, and that also makes a lot of sense too. In the AB 1629 system, we pointed out there was a concept called a labor-driven operating allocation, and that it was not based on cost. Rather, it was an add-on based on really the use of hired staff rather than contracted staff. And we estimated its value to be $168 million and suggested that it could be reused to pay for things like culture change, or to help nursing homes develop assisted living programs or dementia care units, or that it was at least a pot of money that was not tied to cost, but instead was a reward or a subsidy to homes. And I'm not sure, the last I heard of this several months ago was that it had been eliminated from the nursing home budget. Just total gone. So you can't use it to build better databases or to help the nursing home industry change or redo or improve or find homes that badly need some capital improvements to their infrastructure because their building is aging, and give them low-cost loans. So, but and I don't know if that money's been restored in the May revise or whether it's totally gone, but that was a recommendation we had. It was recommendation number 8 for alternative uses of that funding. We also recommended establishing an occupancy provision. In a cost-based system like California is using, if a person leaves the nursing home, the per diem that is paid, the costs are still there. So the per diem paid for the remaining people goes up. See, so money does not follow the person in a cost-based system. It stays with the home. And so potentially then, as a home got less and less people in it, the state would give them more and more money per person. Well, about 20 states stopped that practice by putting an occupancy trigger in there, saying we're not going to adjust your per diem if your occupancy falls below a certain level. And that's and the rhetoric is almost always the same that the state budget staff used to explain this as a policy. We don't want to pay for empty beds. Right? And that's used. That's the line. That's the kind of the vocabulary that's used to describe it. The industry, of course, hates it, because it means they're losing some of their costs. But they get all of their costs down to a certain level of occupancy, typically 85% or 90%, and then after that they start losing some of that per diem as their occupancy drops. So they're not. So it's a stimulus or an incentive to go out and get more patients to fill those beds. Okay, so we have a discussion of that in our report. We suggested some things such as the review of non-residential service rates for the Department of Developmental Services. They have great methodologies from almost all their rates, but basically the budget freeze has totally nullified those methodologies. There are really some excellent methodological rate concepts there. We recommended that there be a study of the need for waiver expansion, because on the one hand, there's a lot of good data showing that waivers are cost effective. And if you control the utilization on them to be sure that only folks who are truly nursing facility eligible or might have gone or probably would have gone, or you would put them into a nursing home if they wanted to go, if only those folks go on a waiver, waivers are extraordinarily cost effective. And you can even tolerate a certain, depending on the cost differences of the waiver versus a nursing home, you can even tolerate folks who wouldn't go into a nursing home, sometimes a lot. And so you can basically pay for 3 people in New Jersey, we found you could pay for 3 people on a waiver and versus 1 in a nursing home. And it didn't matter if one of those people wouldn't have gone in the nursing home, you were still cost effective. You could even tolerate that amount of non-nursing home eligible people on your waiver. But there's kind of an undertone of skepticism among department staffs, including department budget staffs, that waivers are cost effective. So what we suggested was that there needed to be a study of this, and I'm pleased to say that the SCAN Foundation and the Department of Healthcare Services are working with researchers at CAMRI, the California Medi-Cal Research Institute, doing such a study, looking at this whole question and issue. It's a 36-month project, and I'm not sure what the timelines are on the release of the results, but at least there is some attention and focus on this issue.
If it's 3 years, are you saying you're at the beginning of this or somewhere in the middle?
I don't know. I believe there's somewhere in the middle, but I don't know the exact timelines. We suggested that there be an expansion of types of residential services for adults in California. Some 6 states have adult foster homes. I like it. I mean, I've been in probably 3 or 4 dozen adult foster homes in Oregon. It's really a nice model. Some 6 states have them: Michigan, Washington, Oregon, 2 or 3 other states. It's hard to get them established. Some states I couldn't. Municipalities in New Jersey fought the idea tooth and nail, along with the Nursing Facility Association. It was just a really hard sled to get any progress there when I was in New Jersey. But nonetheless, assisted living and adult foster homes are good residential models, and they provide housing alternatives when housing is scarce for people who are poor and have chronic health care conditions. And basically, I think the more you have, the better off you are. I mean, in terms of residential options for people on waivers. We also suggested the increase of use of provider fees. Roughly 30 states have them around nursing facilities, a smaller number around hospitals, some have them on ICFMRs. About 10 states use them in areas like home health and personal care. And there is some, again, reluctance to push provider fees, but it's part of revenue maximization, and I think it's states that don't have money should be really just as rigorous as they can in figuring out every way to maximize the revenue for these programs that they can.
Did you examine any aspect of the long-term care insurance industry related to payment?
No, I didn't.
The housing part.
We didn't cover the impact of the RWJ partnership programs that sponsored a lot of long-term care insurance. It's just a large and complicated area, and it was just one that we tried to make some decision that perhaps it was kind of, our report at 300 pages was sort of long enough, you know.
Well, no, because of course what my consultant, Mr. McLaughlin, just leaned over to chat with me about is, you know, all of these ideas, very innovative and important, and would certainly add to the mix for how we are going to support a true home and community-based care system for California's seniors and persons with disabilities. But the constant question is, how are we going to pay for it, and how are we going to use the systems that are already in place, including the long-term care insurance industry that I actually have another bill with Commissioner Dave Jones and I are working on trying to establish some certainty in that market. But that is, we are going forward. I mean, anyone from the business community or the insurance industry, anyone looking at the clear demographic shift going on in our state and our country have to be looking at how they can certainly partner with those who have resources, looking ahead as to how we're going to pay for our care, essentially. And so, that's probably a topic for another hearing, maybe.
It's an excellent point, ma'am. I would like to talk about some new federal initiatives that have come out. A significant one is on Medicaid health homes. A section, and this is again out of the Affordable Health Care Act, which is this amazing cornucopia. It is just incredible what has been going on in the last 3 to 4 months at the national health care level. But Section 2703 of the Affordable Health Care Act authorizes a state option under Medicaid to provide a health home for individuals with chronic conditions. And one of the eye-popping points about this is that it's a 90% federal match. So the feds will pick up 90% of the costs. And it is basically a primary care case management system where the primary care managers are really the physician assistant, the nurse practitioner, a healthcare team. And chronic conditions are kind of vaguely defined, actually. It says an individual has to have 2 chronic conditions, or 1 and a risk of a second, or have a serious and persistent mental health problem. And it does give some examples of chronic conditions: mental health, substance abuse, asthma, diabetes, heart disease, or being overweight by a certain body mass measurement. To become eligible for the match, the state would have to submit a state plan amendment. Such amendments became possible on January 1 of this year. On November 16th of last year, CMS issued policy guidance on how states can go about applying, and the basic process is a letter of request. And as of May 11th, 8 states have submitted letters of request. The written testimony identifies what those states are, names the states. As of May 11th, however, no states have yet submitted state plan amendments. And the November 16th guidance shows that CMS is open to all kinds of reimbursements: tiered capitation rates, case rates, bundled rates, any kind of case management reimbursement you can imagine it's willing to consider paying. And that so that provision of the Health Care Act was codified at Title 19, Section 1945 of the Social Security Act, and it represents a significant opportunity for state governments to control utilization not only of hospital services but also of nursing facility services. And especially when used with dual eligibles, folks who are dually eligibles for both those programs, it can result in cost savings for Medicaid programs. So here's an option that the state of California has not submitted a letter of request to inquire about. It is a 90% federal match and has a possibility of saving money for the state. Okay. The Affordable Health Care Act in Section 1202 requires that Medicaid reimburse primary care providers at a parity with Medicare rates in 2013 and 2014. And so the issues there are trying to figure out what procedure codes are involved and what's primary care and what are the feds going to let you get reimbursement for. But for 2 years, it represents a windfall to California doctors of millions of dollars more that Medicaid can pay them for primary care that it can't afford to pay them now. This goes away at the end of 2014. So the challenges around this are to figure out how you get savings out of this, how you improve quality of care, how you get savings in a way that might give you some hope for sustainability of this in 2015 and beyond, requesting your congressional delegation to continue this 100% federal funding for this enhanced primary care rate. The feds are going to pay for this. I mean, it's an activity that the state simply needs to work through the implementation challenges and take advantage of these federal offers. Now, there is an almost program. It's called and I call it almost because it looks better on paper than it actually is in actuality, as currently written in the Affordable Health Care Act. And this is called the Medicare Community-Based Care Transitions Program. And it's a 5-year program. It began April 12th, about 35 days ago or so, and the goals of the program are to improve transitions of beneficiaries from inpatient hospital settings to other care settings. That's the transition. And it wants to improve quality of care and especially to reduce readmissions. See, I mean, readmissions, there's a lot of recent concern over readmissions because just an astoundingly high fraction of people go back to the home back to the hospital within 30 days. And so the intent of the act is to focus on hospitals with high readmission rates and then have them team up with a community-based organization to improve the transition. And one limitation is that the number of hospitals who can participate. In California, there's 24 of them who have high readmission rates, and my written testimony gives a list of what those 24 are. Community-based organizations are really sort of defined as community-based organizations that provide care transition services, but unfortunately that definition tends to knock out government-related organizations like area agencies on aging and aging and disability resource centers that are connected with counties. So, and it also requires composition of board requirements. You have to have a certain kind of board. And so there are just a lot of organizations that would be willing to participate in this but are disqualified because they're somehow affiliated with a county government mostly, or they can't or won't or don't want to have such a board. And so this is an example of where if the federal Medicare program fixes these problems in this section, it really would be an excellent opportunity to take advantage of where possible in the state. On April 9th, I'm switching now to data processing funding, okay? On April 19th, 2011, CMS, the Federal Medicare and Medicare Services, the Center for Medicare and Medicare Services, gave a final rule confirming the 90% federal match for data processing changes for design, implementation, and installation of eligibility determination systems, and also the health insurance benefits exchange. And this 90% match will be available through December 31st, 2015. Now, to me, a statewide instrument that collects a lot of data on assessments for all your people in long-term care, that assessment instrument is used to confirm eligibility, functional eligibility for long-term care. So I think of it as an eligibility determination system. It certainly can be cast in that light as a reasonable argument. And if you fold it into MMIS, then you tie it into cost data and claims matching and all of that. And so my way of thinking is that there may be opportunities in such an application and fitting in work on a database into an APD like this. Most state Medicaid agencies hate APDs because they're cumbersome, they're bureaucratic. The feds nitpick you to death with 40,000 questions, death by questioning, Chinese water torture, question. But basically, the money's only available for a short time, and it's worthwhile making the effort. And my suggestion is, just if you don't want to do the work, hire a contractor. Put it out for bid, get somebody, and just get it done.
Although, unfortunately, I mean, this is all very welcome news for my ears to hear, about the availability of federal match up to 90% for a variety of these programs. But without a budget, the state is unable to meet the match. And so I think, we are stuck in this, sort of circular argument with ourselves here as legislators that, unless we get the budget done, we won't be able to do any of these creative programs. So, let's hope we get the budget done.
I'd like to give some practical examples about expanding nursing home transition work. And in the testimony, this comments mostly focus on nursing homes. As of this month, Texas has helped approximately 24,000 people leave nursing homes, roughly over 10 years, roughly 2,400 people a year in Texas. Annual nursing home costs in Texas are roughly $45,000, and community costs are much lower. Texas has 2/3 the population of California, so roughly, if you scale Texas's 24.8 million people to California's roughly 37 million people, that would be about 3,600 people per year in California. If California could do what a large state like Texas did in terms of nursing home transition. And in Texas, money follows the person. That is, the savings from reducing the nursing home utilization go directly to pay for the home and community-based care. Not all of them, because the state keeps some, but most do. New Jersey has helped 500 people a year, is hiring more staff and moving that up to a 650 a year now. New Jersey's got 8.7 million people. Again, if you scale that up to California, that would be roughly, the 500 people would be roughly 2,800 people a year. Pennsylvania is an outstanding role model for California, a large state that has made great progress on integrating long-term care, unified databases, nursing home transition. They roughly help 1,600 people a year leave the nursing homes. And scaled to California, Pennsylvania's 12.6 million people compared to California's population. That in California, that'd be roughly 4,600 persons a year in California. Now, Pennsylvania, in 2010, Pennsylvania staff reported that their total savings in nursing home budget exceeded over $200 million because of this program, and that they save an average of $119 per day on the transition, and that since 2006, the cumulative total has been roughly 6,300 nursing home residents have been helped to leave, and the number of Medicaid paid days in Pennsylvania that have declined from 2002 to now, they've declined 600,000 paid days a year. So, my question is, if large states like Pennsylvania and Texas can do this, and smaller states like New Jersey can do this, why can't California? And now Michigan, I'm just throwing in a fourth example here. Michigan reports that since 2008, their nursing home transition program has saved $65 million in state funds, kind of a smaller state. Now, California currently participates in the federal program called Money Follows the Person. On the one hand, it's a very generous policy. You get the 75% match for a year after you to help someone leave a nursing home. You get some of your admin expenses paid for at 100%. But the feds, they also give, but they also taketh away. There's a lot of restrictions on the program. You can't put someone in an alternative residential setting you have to have 4 or fewer people. You can't put them in a foster home with 5 people. You can't put seniors in assisted living and get the enhanced match. There's also a load of quality care requirements that don't exist in the regular Medicaid program, like the requirement for a 24/7 backup service, which is not in the Code of Federal Regulations, isn't required of personal care expenditures. So my belief is that states, California, should substantially expand their nursing home transition program, keep MFP, use some of the same administrative staff to help you, but don't try to shoehorn all of nursing home transition in under the MFP program. Go out and hire staff in ILCs and area agencies on aging and build nursing home transition programs in many parts of the state as you can to take advantage of the savings that you could get in your nursing home budget. If you want to get the small amounts, the $3.5 million for the contractor, if you want to get a little bit of database money or the 10% match, this is a place you can get it. See, the money's there. And when you're talking about a $3.8 billion plus nursing home budget, surely you could make some savings in that. I mean, and then take some of those savings and put them into other programs. I know I only have a few minutes left, so I want to add one more comment on revenue maximization. The state would benefit by having another master services agreement for revenue maximization like it did in 2003, 2008. And revenue maximization now really consists of two kinds of activities. One are business efficiency, things like better cost allocation plans, Medicare Part D recoveries, third-party liability stuff, and maximizing cost sharing and copay by beneficiaries. And secondly, there's some classic techniques like provider taxes, upper payment limits, but I think the state just has to go out and with a lot of self-discipline and endurance just relentlessly scrounge for these revenue maximization possibilities and do whatever you can in these regards. The other people have said this too. The 2004 revenue maximization study by the California Endowment Fund kind of also indicated that the state would benefit by using more provider taxes. So our report is not alone in calling for these revenue maximization things. Finally, I'd also like to say that the ability of the state to make huge cuts is getting really circumscribed at the federal level. On April 29th, 2011, CMS really published proposed rules putting states on notice that they cannot simply go make willy-nilly large cuts to programs. In November of 2010, CMS denied California's state plan amendment to cut the ADHC program, and it did so because of concerns with a provision of the Social Security Act 1902A30, which basically says you have to pay rates that are high enough to provide access to providers. That's the heart of that rule. And the state was unable to persuade CMS that these cuts would in fact not affect access. So the draconian cuts like this and now that the feds have come out publicly, and what they want is states to go on a 5-year review period where they actually have to study their rates and provide evidence to CMS that the rates are high enough to provide access, that it's going to get harder to survive federal scrutiny. Seeing a state that doesn't have a database, doesn't have the foggiest idea where people in ADHC are going to go or MSSP are going to go. Maybe they go to nursing homes, maybe they don't. We don't know what the access problems are. The CMS is just increasingly concerned at the federal level at the 30 states that have cut home and community-based care services, and is now basically sending a clear signal to states to, hey, slow down a little bit, study your program, see what's going on around access before you. We're not going to accept these kinds of cuts, large cuts to programs. So that's some recent events that are going on in the larger Medicare and Medicaid world around us that bear on the possibilities of financing and savings for California.
My goodness, what you have just told us in the space of the last half hour or so about very recent developments, post the completion of this report that the previous California Health and Human Services Agency secretary had access to. Because this report that, as I say, I have not read the entire thing in depth.
Nobody does.
But,
don't.
No, but somebody has to.
No, everybody just reads parts of it that they like. Nobody reads the whole thing.
This report was made available to the previous administration, in the fall of 2009. We are now, a year and some plus from the date that this report and these recommendations were submitted. In the change in administration, Have you had the sense that there are additional communication points that we are going to be having with Secretary Dooley, others that will be really addressing this in its totality related to all of our continuing budget struggles? And, just to hone in just for a second again on Adult Day, that this program is slated for elimination, but, perhaps restored in some fashion, at least at half funding. I think at least that's the Assembly position, $85 million, not $25 million. That we still have to get permission from CMMS for approval of these kinds of changes. Do you sense that that kind of approval will not be forthcoming based on what you just said?
I think that
they're moving to a September 1.
Such requester was judged by the November. I read the denial of the Adult Day Health Care State Plan amendments that CMS issued in November of 2010, and they very clearly are skeptical and they want the evidence and want the proof. And in the letter, they clearly say that California couldn't supply them the evidence, and that's why they're denying the amendment request. Mm-hmm. So, but I'm not. It's been a long time since I grew up in San Francisco, and I certainly wouldn't presume to make suggestions about the current events in Sacramento, and I would leave those suggestions to folks who are more on what to do with the new administration. I'd leave those suggestions to folks who are more familiar with current events here.
Absolutely. All right. Well, thank you very, very much. It is now 5 o'clock. I want to congratulate everyone who stayed for the whole hearing, and I'm sorry that I know that some of our other members had to attend to other appointments, but I don't know if there is anyone here who had any public comment. Anyone have a burning comment that they wish to make? I see some young people who are here in the audience. Appreciate that, because what you are listening to is, certainly going to not only affect your parents or your grandparents, but you in the future. So, because you guys are going to be the ones taking care of us, right? So, my children, I tell them I plan to be a burden on them. The previous generation, we don't want to be a burden on you. I've already told my kids I plan to be. So with that, I want to again thank our staff and the sergeants and all of our witnesses, and this hearing is adjourned. Thank you.